Okay, so we have a very special guest today, and his name is Jay, and he is a neurosurgical resident, and he's just going to be here talking about how he got into neurosurgery and like how he like after he qualified as a doctor and how his journey was essentially. So I'll hand over to him now.
Yeah, thank you very much. My name is Jake Tetcher. I'm currently a neurosurgery registrar. I work in Nottingham. At the moment, I'm an ST4, which means I'm about midway through my training in neurosurgery. Neurosurgery goes from ST1 to ST8, so I'm about halfway through at the moment, or just under halfway through. I understand we've got people who are pre-med school and people who are in med school on this webinar. So I'll go over sort of my background, how I got into med school, and things I did in medical school to prepare me for um, becoming a neurosurgery registrar. Then I'll go over sort of how I got into neurosurgery training after medical school. Um, I'll go over what neurosurgery is, and what we do on a daily basis, what it's like, and then try and give you some pointers specifically for neurosurgery if there's anyone who wants that. Is there anyone in the audience that wants to do neurosurgery specifically? Put in the chat if you want to.
I'm an aspiring
So
neurosurgeon
we've got people.
myself, and this whole community is about like aspiring surgeons. So we will have a couple.
Okay, good. So my journey starts um, in school, I suppose. I was born and brought up in Leicester, which is a city near Nottingham, about 40 minutes away. And I went to a state comprehensive school in Leicester. Um, and, you know, I know that medical admissions have changed a lot since I went to med school. But back when I was applying, which was a long time ago now, this was 2012 was when I started med school. Um, we had sort of, the GCSEs that were looked at, the aptitude tests. So for me, it was the UK CAT and the BMAT, which is now discontinued. I think that was assessed, and your personal statement and interview. And the way I kind of decided where to apply to medical school was I tried to be strategic about it. I put a few universities that were sort of relied heavily on aptitude tests, a few that relied heavily on GCSEs, a few that relied heavily on interview. And luckily, my portfolio was quite strong in all areas. So I thought, if I choose a varied selection of universities, then if the interview were to go wrong or something were to go wrong in the aptitude test, at least I'd have tailored my applications towards the universities in that way. In the end, I actually only got one offer, so I only got an offer from Leicester University, and that was as a reserve as well. So I was put on the waiting list and got an offer, and managed to get in and went to Leicester Medical School. In terms of applying to medicine, as I said, it's changed quite a lot since I did it. But essentially, I think you should start thinking about it quite early. The fact that you're holding this webinar shows that you're already thinking about it early, which is good. You should start thinking about it early. Sort of around about when you're taking your GCSEs. As you know, medical school applications are quite tough already. So I would advise you really research what med schools you're applying to, what they concentrate on in terms of applications. There'll be some med schools that rely heavily on aptitude tests, some that rely more on interview, and also different med schools will do different types of interviews. So, for example, Leicester, when I was applying, Leicester did multiple mini interviews, and Nottingham, for example, medical school did one-to-one interviews only. So there's a question in the chat, where did I go? So I went to Leicester Medical School. Leicester does, for example, multiple mini interviews, which is great because it's essentially sort of 8 to 12 different booths, and every booth is targeted towards something different. So, my first station was about why did I want to go to medical school, why specifically this university, etc. And the second booth was about reading a research paper and answering some questions about that. The third booth was a role play scenario where a patient had come in and was really upset, and they saw how you kind of talk to the patient and manage that. So essentially looked at communication skills, and so on. And also that multiple minute interview setting also allows you to kind of reset each station. So, you might do really well in one station, then the next station might not go so well, and then you have a fresh start for the next meeting. So I think that system works quite well, at least for me. And so I played to my sort of advantages and got an offer from Leicester. Traditional interviews are also great, but I find with traditional interviews that if things start to not go your way, it's hard to kind of draw it back sometimes. So, so that's something to keep in mind as well. I know the aptitude tests have changed a little bit, but back when I did it, it was called UK CAT, and you kind of just need to play to your strengths. If you think you get a really strong UK CAT score or aptitude test score, just apply to universities that look at that heavily. So it's but apply to medical schools about playing to your strengths, and then obviously you consider location and things as well. And the thing is, every medical school is very similar, pretty much the same. At the end of the day, you're gonna graduate and have a medical degree. So there's not too much difference between medical schools. Tying this all into neurosurgery, one thing, if you really want to do neurosurgery and you're looking to do medicine still, get into medical school, one thing to maybe consider at this stage is whether your university is linked to a neurosurgery department. So, for example, I went to Leicester Medical School, and Leicester does not have a neurosurgery service. The nearest neurosurgery service to Leicester is Nottingham. So I didn't do any neurosurgery whilst I was at medical school, and so that limited my exposure to neurosurgery in med school, and also meant that I only realised I really wanted neurosurgery after I graduated. So that's something to think about. I'll come on to this a bit later, but neurosurgery is a regional specialty, and not every hospital in the UK or even every hospital trust in the UK provides neurosurgical services. So that's one thing to think about, whether your med school is linked to a hospital that provides neurosurgery or not. If you do end up at a medical school that doesn't have an attached neurosurgical centre, then that's not the end of the world. I know a couple of people currently in that situation at med school. All you have to do then is potentially just get some contacts and set up a summer placement in your summer holidays for a week or so, and shadow the nearest neurosurgical centre to you. So I'll kind of move on a little bit, because I think the more beneficial things for you guys might be the things I'm about to talk about. So I'll talk more about neurosurgery and what kind of the process is like. So after you graduate from medical school, you do your 5 years or 6 years if you integrated in the BSc. So I integrated. I took a year out from Leicester, actually, went to Imperial and did neurosciences as a BSc. So I did 6 years of med school, and then the system has now changed. But back when I graduated, we could select where we wanted to go and rank our location. So I selected to go and do my F1 and F2 in Nottingham, and they used to look at your score and how well you did at med school, and then the people who did the best get the first choice, and second best get the second choice, and so on. And then you were also able to pick your rotations as F1 and F2 at that point as well. So I was able to pick to do neurosurgery as an F1 in Nottingham, which was really good for me because it kind of gave me a flavour of neurosurgery as a newly graduated doctor. I know the system's changed now, so you can't necessarily pick those things as well, but that's how it was for me. Now, getting into neurosurgery training is a very tough process, and it will only keep getting tougher, as with any specialty training. So it's important to, again, start early. And by early, I mean in medical school, probably, to think about tailoring your portfolio towards a neurosurgical career. The way you apply to neurosurgery is similar to other specialties. When you're in your foundation year 2, around about November, December time, you'll be submitting your application. And if you're shortlisted for interview, you'll get an interview around about February, March time. And then you'll find out whether you were successful or not a few months after that. Neurosurgery training is competitive. Approximately, the year I applied, I think around 300 people applied, and there were 13 or 14 jobs only in the whole country, not including academic jobs. There are some academic jobs as well available. So in total, there'll be about 18 jobs maybe in the country per year. And most of the people who are shortlisted for neurosurgery will have very competitive CVs. So it's important to make yourself stand out at interview and also in your CV, on your portfolio. In terms of things that you should think about in medical school, I'd say to tailor your CV to neurosurgery is try and split up into different domains. So when you come to apply for neurosurgical training, there are several things they look at. The first thing they look at is undergraduate prizes. So if you've got any certificates of outstanding achievement in exams, or if you've won any prizes or awards or medals for essays, student competitions, projects or anything, then that would count. The next thing they look at is postgraduate prizes. So anything you do after medical school of a similar nature, that counts, but they're separated into undergraduate and postgraduate. So it's important to get things at medical school and after medical school in terms of prizes. And third thing is they look at exams. So exams is something you can only do after medical school, and that means postgraduate exams. So if anyone wants to be a surgeon, has to do a set of exams after medical school, called the MRCS exams, so membership of the Royal College of Surgeons. And it's a 2-part exam. The first part is an online part. It used to be in paper, but since COVID, it's online. It's a multiple choice exam, and you can do that exam from when you're an F1 onwards. So I'd encourage everyone to do that as early as possible because it just gets out of the way. Once you've done that exam, you can do Part B, MRCS Part B, which is an OSCE practical type exam in person. And if you do the full set of exams before you apply for neurosurgical training in your F1, F2 years, then you'll get the maximum points when you apply for neurosurgery. They also look on the application form at any further degrees you've done. So any integrated BScs you've done, any masters you've done, any PhDs you've done. And there will be some people that apply to neurosurgery that will have PhDs or a high-level master's degree. So it's something to consider if you're really into academics. But you don't necessarily have to have one. But every year there'll be 1 or 2 people who get in who will have a PhD in something to do with neurosurgery. They also look at courses. Again, courses you can only kind of do after you graduate from medical school. So there's various different courses that you can do to help your career. Surgical courses, trauma courses, things like that can help get your CV stronger. If anyone wants to know the name of specific courses to do, just let me know in the chat, and I can go through that as well. They also look at things like research projects. So publications essentially are quite big in neurosurgery, and that's something to think about from medical school, because doing a research project can take anywhere from 6 months to several years. I've had projects that I've published in a year, and I've had projects that have been published about 8 years afterwards. So you have to start really early. And the thing is, at the start of your project, you'll not know what kind of project you have, whether you've got a long-term project or a short-term. So in med school, I started 2 or 3 projects, and eventually they got published when I was an F3, so a long time after. So it's important to start thinking about projects in medical school and to get involved in research, either in your local neurosurgery department, but it doesn't have to be neurosurgical research. It can be anything. It can be something in anesthetics. It can be something in neurology. It can be something completely unrelated to neurosurgery. But try and make it something related to neurosurgery. But if you're not able to find a neurosurgery project, that's fine. Do something at least in terms of research in med school, and get involved in 2 or 3 projects, because they will take time to get published, and they can take years to get published. Something else they look at is audits on the application form. Audits, again, something you can do as a med student, and you should try and get involved in audits as a med student if you can. I'm sure most of you are aware what audits are, but I'll go through it just in case. Audits are essentially looking at, they're a type of quality improvement project where you look at something that's you think is not being done optimally in the hospital, and you compare that said thing to a guideline, and you see how well you compare to the guideline. For example, in neurosurgery, maybe we might look at blood thinning medications in neurosurgery. There are specific NICE guidelines about when to stop blood thinning medication when someone's undergoing a neurosurgical procedure. And maybe I can look at a project, an audit, looking at if patients in my department stop blood thinning tablets in time for surgery or not, compared to the guidelines, the NICE guidelines. And I might find that 95% of patients do, but 5% of patients don't because of an error. And I can make a change in our practice and then re-audit it, and hopefully I'd find an improvement. So that's an audit, essentially. It's a project that looks to improve quality of healthcare delivery and healthcare service. So that's something to get involved in. And again, you want to get involved in maybe 2 or 3 audits in med school if you can. It's a lot of work, I know, but it's important to start all this early, because on the application form for neurosurgery, you can, at least at the moment, you can put a maximum of 5 research projects and 5 audits. So you want to try and max out everything on the form if you can. They also look at extracurricular activities in the neurosurgery application form, specifically things that make you good at hand-eye coordination. So it could be anything. It could be sports related. It could be arts and crafts related. It could be an instrument, musical instrument that you play. So think about the hobbies you have, and try and list it down on the application form. And if you're struggling, you can always pick something new up. You can pick up a new instrument. You can pick up origami. You can pick something up to put down in the application form. And then the other thing they look at is leadership on the application form. So try and get involved whilst you're in medical school. Try and get involved in some sort of societies. For example, this kind of thing would go in an application form, or an academic society. You could set up a neurosurgery society if your medical school doesn't have one. Most medical schools do nowadays, and that counts towards leadership. Things like that can also happen after medical school as well. You can get involved in societies, postgraduate societies as well, and the same goes for research and audits and everything. You can continue to do that as an F1 and F2 as well. But with all these things, it's important to start early, because they take time to get completed and published for you to be able to put in the application form by foundation year 2. And that process of when you graduate from med school as an F1 to applying for neurosurgery is only about 1.5 years. So it's a very quick process. So if you only start doing things when you're an F1, you have 1.5 years to optimize your CV, which sometimes is not enough time. So I think the main takeaway from all that is start early, start in year 2 or 3 in med school, just thinking about these things and getting involved in things early on. So there's a message on chat saying to just go over some course recommendations. So yeah, the courses that will be helpful for neurosurgery, and these are courses to do after you qualify as a doctor, so in your F1, F2 years. So there's some essential courses that you need, so you might as well get them done. Basic surgical skills is a course run by the Royal College of Surgeons, which any surgical trainee has to do. So that's one, basic surgical skills. Another one is ATLS, which is an advanced trauma and life support course. And ATLS is also mandatory for most surgical specialties. So that's another one to get done. So I'd say those 2 you might as well get done, because they're usually mandatory for surgical trainees anyway. And then that leaves, as I said, there's usually 5 boxes for most sections. So that leaves 3 more courses for you to do to max out that section on your application form. And that can be anything really. there are lots of sort of neurosurgery courses running across the country, and neurosurgery conferences running across the country. You can Google them and attend them. St George's University, I know, St George's Hospital, sorry, they do a neurosurgical drill course where you get used to the drills that are used in neurosurgery. King's College used to do a neuroanatomy course, which is quite good as well. And there are some online courses you can do as well to do with neurosurgery. If you Google them, they may also count. So those are all kind of courses that you can look into. But I definitely recommend basic surgical skills and ATLS as two courses to do because you'll need them anyway. So I'll move on to what neurosurgery is and what the training is like, and then we can take some questions. Hopefully, it'll only be 5-10 minutes longer. So neurosurgery is essentially surgery to do with the brain and spinal cord. It's an interesting specialty, and it's very emergency focused as well. I'd say about 40 to 50% of all our work is emergencies, and the remaining is elective work. We're probably the specialty that operate out of hours the most, and the things we see on calls will be things like bleeds in the brain, sometimes brain tumors, spinal cord tumors, hydrocephalus, so buildup of water on the brain. Those are the main sort of things we see on call that we operate on a daily basis. Elective neurosurgery, so planned neurosurgery, is a whole different game, and that can be split into subspecialties. So there are about 6 or 7 subspecialties in neurosurgery. For example, the skull-based neurosurgery that deals with pathology to do with tumors of the base of the skull, for example, acoustic neuromas. Vascular neurosurgery deals with the blood vessels in the brain and treating aneurysms. Pediatric neurosurgery deals with the treatment of children with neurosurgical issues. Spines is a separate specialty in neurosurgery. And pituitary tumors is another specialty as well. And there are a few more specialties like functional neurosurgery, which deals with treatment of movement disorders, like Parkinson's disease, for example. So there are, and there's neuro-oncology, which deals with brain tumors. So there are lots of subspecialties in neurosurgery, and you kind of go through your training and pick a subspecialty to go into once you're towards the end of your training. Day-to-day wise, in neurosurgery, we do our normal days where we are sometimes operating electively on planned cases, or we do our on-call shifts. On-call shifts is when we're in the hospital taking referrals from a catchment area, and the catchment area for Nottingham is about 3 million people. We cover the entire East Midlands. So anyone who has an emergency neurosurgery problem within the East Midlands will come to our neurosurgical centre in Nottingham. And we also do night shifts as well, which is the same. You cover the entire East Midlands in terms of neurosurgical issues. I'll stop there, and I'll think it would probably be better for you guys to ask me questions now if I've missed anything out, or if you want to know anything specific, because I know it's already 30 minutes.
I have a question. Why did you pick Nottingham? It's like for your neurosurgical residency.
For me, it was because I'm originally from Leicester, and my family is based around the East Midlands. That's why I picked Nottingham, and also I did my first neurosurgery job as an F1 in Nottingham, so I already knew the department quite well, and I liked it quite a lot when I was working here. So those are the main two reasons. As I said, with neurosurgery, you will have to, if you are a successful interview, you essentially get to rank your preferences. And there are only 30, I think 31 or 32 neurosurgical centres in the UK. So you rank them 1 to 32. And then based on your score at interview and your portfolio, you get your selection essentially. So I was lucky that I got my first choice, but most of the time in neurosurgery, you have to be prepared to move away from where you're studying, where you're located, because it's very competitive. But I got lucky in the fact that I got Nottingham. But the main reason, was for me was family and the fact that I already knew the department.
All right, thank you very much. Okay, I think we have a question.
Yeah, at what stage in your training were you able to lead a surgery, or is it only until you become a consultant? Um, well, the thing with surgical training is that it's a sort of continuous spectrum of improving every day, right? So there's no sort of one day where you automatically become the lead surgeon until you're a consultant. But as a registrar in neurosurgery, uh, we usually will deal with most things that are emergency based. So most emergency operating, I'd say around about 80% of emergency operating is registrar led, and consultants won't have to come in overnight. There are some emergency cases that are more complex, for which I would call a consultant in. But most emergency cases, I'll operate alone overnight. Elective neurosurgery is different. Elective neurosurgery plan lists are all consultant led, and you only get to kind of do a full operation in elective neurosurgery later down the line when you're a more senior registrar. So when maybe in a few years' time for me. So yeah, it's a matter of sort of continuous improvement, but it's not there's not sort of one moment where you become independent. Um, Neurosurgery training lasts from ST1 to ST8. So it's a run through training program, which means that after F1 and F2, you don't have to do core surgical training like you would have to do for general surgery, for example. You will apply straight to neurosurgery. As an ST1, you'll still be classed as a senior house officer, and so your main jobs as an ST1 will be ward based rather than operative. And as an ST2, it's also similar, but you start to step up to the registrar rota as an ST2. And as an ST3 is when you officially become a registrar in neurosurgery, and that's when you kind of will start to do most things emergency wise on your own. And as you get more and more comfortable, you'll start to do more and more on your own in terms of emergencies. But yeah, elective neurosurgery is still something that will be something that senior neurosurgeon registrars will kind of perform when they're a bit further into training.
All right, I think we will move on. I think my mic is acting up a little bit, so sorry about that. But yeah, we'll move on now. And if you have any more questions for Jay, I'm sure he will stick around and answer them in the chat. But yeah, today we're gonna for diseases, we're gonna go over a diabetic macular edema, and so please listen carefully because we have interacted with the feedback, and there is an interactive quiz at the end, and that's quite helpful as well. So yeah, I'll just hand over to Ben now, so then he can do this part of the presentation.
Hi guys, can you hear me?
Yeah, I can hear you.
Okay. Uh, the disease we're going to do today is DME, which is diabetic macular edema. So it's a complication of diabetes where fluid builds up in the macula, which is the part of the retina which is used for vision, including seeing details in the eyes and then colors. It's caused by the breakdown of the blood retinal barrier due to high blood sugar levels. And so it's basically when there's too much, be it water, blood, plasma flowing through the blood vessels in the eyes. So it leads to leakage of fluid, which affects you seeing, and it leads to swelling, which is also known as edema, and then the thickening of the macula. What increases how long you've had diabetes for increases the risk of getting it, because that means you're more likely to have high blood pressure, which is hypertension, hyperlipidemia, which means high cholesterol, and it affects your body because you have more fats, you have cholesterol, which blocks the arteries and then prevents oxygen or blood from flowing through the arteries. And then we have nephropathy, which is chronic kidney disease. And I feel like kidney is the biggest risk factor for getting DME because the kidney is responsible for ultrafiltration, which means that's what's help you with like, reducing fluids in your body, draining glucose, proteins, amino acids, and urea. So if your body's not able to regulate how much water you lose or how much water you gain, then you have too much fluid going through the blood vessels, which can burst probably and also lead to leakage. And then higher A1C levels, which are hemoglobin 1C, which is a test which sees how much diabetes you have. If you're pre-diabetic, that's between 5.6. It's basically measured via a percentage. So it's from 5.6 to 6.4, which means you're pre-diabetic. And then anything above 6.4 means you actually have diabetes. So it's at that level where you have to start taking precautions to reduce your blood glucose levels. How does, yeah, I think I went over this, but okay. Increased vascular permeability, which means if you have decreased renal functions like your kidney, you have kidney problems, then you're less able, like the endothelial lining of the blood vessels in your kidney are less likely to release water, which means you have more water in your blood than you take out, which causes an imbalance. So lipids, erythrocytes, which are basically they're too big, the molecules are too big to pass from the blood vessels into the retina. And so it can cause damage to the retina. And then retinal leakage, yeah, when the endothelial wall becomes more porous. Symptoms of DME. The main issue with DME is that it's normally asymptomatic. So a patient could present with a DME for 3, 4 months, a couple months before they actually start seeing symptoms, at which point it's a bit too late to do something. But the symptoms normally reported by patients are blurry vision or double vision, spots in your vision, which may look like gray or black specks, difficulty seeing colors, dark spots also known as scotomas, straight lines that you see as bent or curved, and then seeing an object which appears bigger when you look at it. So in addition to an eye exam, which is normally carried out by optometrists, which is basically they produce a 3D image of your eyes and then they inspect it to see what parts of the eyes are damaged, whether it's the retina where the macula is located in. They use these other tests in conjunction with that as well. Optical coherence tomography, which is an imaging test which basically measures the thickness of your retina and optic nerve. Fluorescein angiography, which is an imaging test that shows the blood vessels in the retina, and then an ambular grid, which uses a grid of horizontal and vertical lines in the visual field test. Most treatments aim to block the VEGF, which is the vascular endothelial growth factor, which is basically a protein which is, it helps new blood vessels grow. If you have more blood vessels, which means there's more fluid, be that plasma or blood, which is flowing through the eyes, so it could leak at any time. So it's like an increased risk of leakage. Steroids that manage inflammation are also another treatment. The most common, these are more like ways to like reduce your risks. So regulating blood glucose, blood pressure, and lipids. So this is by exercising regularly, eating healthy, which means not eating foods that are high in protein, food that are high in fat. Regular ophthalmologic follow-ups. So basically seeing the eye doctor like regularly, going for checkups regularly. Pharmacological therapy, which are that's the anti-VEGF agents which are put into the vitreous humor, which is like a gel-like portion behind the retina, which basically helps you with vision. Then you have drugs like Ozurdex and Iluvene, which are steroid implants implanted into your eye. Focal or grid laser photocoagulation, which basically seals the blood vessels in your eyes to stop leakage. And then they're more like more serious, like more extreme cases where you have to go for photocoagulation because it has a lot of risk. Like they're normally risky surgery, but going for photocoagulation, there could be a problem in surgery where the surgeon mistakenly cuts a blood vessel to like your optic nerve or something, and then you're instantly paralyzed. So they're like the last resort for surgeons. Then you have vitrectomy, which is where the surgeon removes scar tissues and cloudy vitreous fluid from your eye. These are questions. So, what is the primary pathophysiological mechanism underlying DME? So basically, what's the main cause of DME? Just put your answers into the chat. Yeah, the answer is B. The breakdown of the blood-retinal barrier. Next question, please. Which of the following is the first-line treatment for center involving DME? So which is like a treatment used by surgeons to like, because there was VEGF, which is one of the most, which is basically something that releases fluid into your eye. Then you have photocoagulation, which is basically the surgeons clotting blood vessels to prevent leakage. Then you have corticosteroids, which is basically steroid implanted into your eyes. And then you have vitrectomy, which is the removal of scar tissue. Next answer, please. Which imaging modality is most commonly used to diagnose and monitor DME? So what do ophthalmologists use to check whether you have DME? This is the one that creates a 3D image scan. See, this is the one that takes a 3D image scan and then measures the thickness of your retina and the optic nerve. Which, and I don't think I really touched on this one. Can you just skip to the answer because I don't think I told them about this one. Yes, in case you didn't know, this was the first drug that was FDA approved in America for treating DME.
All right, thank you so much, Ben. That was really helpful. I hope everyone found it helpful too, and also really informative. We'll be moving on to the structure of the NHS now, which is really important for interviews because it shows that you're well read and well informed about the NHS and the healthcare system in the UK. And so it shows that you understand how care is provided, and that you're ready to be a medic and support the NHS in its goals. So it shows that, it shows that you're willing to be a medical student. So if you remember from the presentation, uh, uh, the the 3-week masterclass we had on personal statements with med camps, it showed that you need to show interest in the medical field and you need to show that you're actually interested in becoming a medic. And so knowing about the NHS structure and additional information like this really does portray you as someone who is well read, who is well informed, and who knows, what they're getting themselves into with a career in medicine and in the NHS. So to just get started, so who is responsible for the NHS? So it is NHS, which is the National Health Service. It is independent of the government, but it depends on the government for funding. So the funding comes from tax and other sources of income. And so the Department of Health and Social Care, which is DHCSE, they set priorities and they prioritize and allocate money, and then the NHS decides on what to spend on it. So like it goes from the government, which gives the funding to the Department of Health and Social Care, and then the Health and Social Care gives like allocates money to the NHS, and then the NHS decides on what to spend on it. So like what they want to spend the fundings on. So that could be medical equipment, that could be medicine, medical imaging. So like maybe CT scanners and MRI scans and like what they can do to improve the patient outcomes and patient healthcare. So that's about efficiency in medicine. And so essentially the government controls the amount of money and then the NHS controls on how it's spent. And then so local healthcare organization. So after, so the care is delivered locally through clinical commissioning groups, which are also known as CCGs. And these are mainly run by GP practices. So CCGs are responsible for delivering budgets in their local area. So that includes hospitals, mental health centers, community care centers, and GP surgeries. And so this way, local needs can be prioritized. And this is especially effective if you have, regional sicknesses, maybe like one region suffers more in a certain illness. And so those fundings can go on to helping treat that specific concern that is in, the local area. So the NHS is divided into four different systems because of the UK and how it's split. So we have NHS England, NHS Scotland, NHS Wales, and Health and Social Care Northern Ireland. And so each nation controls its own healthcare policy and governance. And this came about through devolution, which we'll go over in the next slide. And this is the transfer of power from the UK government to devolved governments. And so devolution essentially means giving local or regional authorities more control over health budgets and decisions rather than everything being controlled by London centrally. So like London is obviously the capital of England. And so the current NHS regional structure, it's divided into regional bodies. So we have NHS England, and that's divided into like NHS London, NHS Midlands, and so they implement national policies, but remain under the central like NHS England oversight. So a clear example that I would recommend you know for interviews is what happened in 2016, and that is the devolution of Greater Manchester. So they decided to have like their own regional structure for Greater Manchester. And so the aim essentially of this devolution was to allow local leaders to target local health priorities. So examples being, so some regions like Greater Manchester may experience higher smoking rates and that leading to problems such as emphysema or bronchitis. And some regions may experience poor mental health. So those fundings can go into those specific areas, those specific diseases, and that helps just target patient healthcare, and that's obviously a pro. And so some advantages and disadvantages is that healthcare can be tailored to local needs. And so that is the best interest of the patient and patient-centered healthcare. So in the next couple weeks for weekly seminars, we'll be going over like medical ethics and like the principles and goals of the NHS like healthcare system. So this will all link together. And so also by devolution, you also have a potential for improved economical productivity because less people will be taking off sick like breaks. as communities will stay healthier because they're getting the targeted treatment they need for that specific region. And this will be able to generate more income for the community, which obviously is a cycle, it's a multiplier effect that can cause more like better healthcare technology for that community as well. And so local leaders are also more accountable for local population. And as I said, the next weekly webinars will be going over how the NHS needs to be accountable to the public. And that is one of their NHS principles. And that's also really useful to know for interviews. And some cons being, so disadvantages being that areas may be vulnerable to like local financial difficulties. So you may have noticed that the north of the UK, they have less like opportunities, especially with finance. And so the standard of care around the north may drop. And this obviously links to how there's a risk between inequality between like richer and poorer regions. So obviously the richer regions are like the lower Midlands or like London, and then the poorer regions might be up north. And so equality and fairness may not apply to the availability of resources. And the NHS is already stretched. The waiting list, the junior doctor strikes, which are happening. And so revising the structure adds more pressure to how, like the NHS is already burdened with a huge workload. So by revising the structure of how the NHS is structured, there may be extra pressure. And so central oversight is important in such a big organization because the NHS is the fifth largest employer in the world. So, having central oversight is important. And so some interview questions that, you might get related to structure of the NHS are how is the NHS funded and organized? What is devolution in healthcare and why might it be beneficial or risky? And so, what do you think about the Greater Manchester's role in NHS devolution? So, this is like they might ask you these questions, and this is when this knowledge comes in handy. So, I have created like an answer framework. So, you should start like broad and talk about how it's funded by the DHC SC, sorry, and move inward. So, zoom in and talk about how the budgets are distributed to through CCGs to address local needs. And you need to show awareness in your answers. So then you can include the example of Greater Manchester that are now in control of their entire health budget. And then you can talk about the pros and cons of that. And that really shows that you're like really well informed about your medical career and you know what the NHS is doing. And that shows that you're actually really interested in medicine. And that will come across in your personal statement, hopefully, and also your interviews. So yeah, that's all I have for interviews. Now can I hand over to Neha for building your support system, please?
Hello everyone, my name is Neha and I'll be presenting on building a good support system around you. I am still ill at the moment, but I'll try my very best to make sure you can all hear me clearly. So why does a good support system matter? Medicine as a course is not just intellectually challenging, but it is also very emotionally demanding. Therefore, building a strong support network can benefit you as a university student in many ways. It can make you more resilient to stress, as the people around you can give you both practical help and emotional reassurance to help you bounce back. You will also feel more grounded in your identity, as those people can help you feel affirmed, secure, and less shaken by external pressures, allowing you to stay true to yourself. Another benefit would be that you'll feel less likely to be burnt out or isolated, as you won't need to be in a mindset that tells you that you have to do it all alone. A beneficial support system for you would be one where you have a group of people or even tools that provide emotional, practical, or mental health support. Your support system may include friends, family, teachers or tutors, mentors or medical professionals, therapists or counselors, or online or peer support groups. Your support system can support you in many different ways, whether you need emotional support, practical support, academic support, or even accountability support. A strong support system is not just helpful, but essential for medical students, as it can help you sustain your mental health, build resilience, and help you thrive both personally and professionally. However, not all relationships are good and benefit you. Some may even cause harm and negatively impact your mental health. Watch out for people who constantly compare or compete with you, people who minimize your stress, or people who drain your energy or discourage your goals. Put up healthy boundaries if you need to as well, and make sure you always strive to protect your peace. You can get loads of support from your peers in your medical journey. Make sure you are in contact with other aspiring medics, as they understand your path like few others can, since they too are also going through the same challenging application process as you are. You can also gain a lot of powerful peer support through student groups, joint interview preparation, and even venting sessions with your friends. And my biggest tip ever would be to avoid comparison culture, as it is always best to work with your peers and support each other in reaching your goals than working against them. Having supportive friends and family is great, but sometimes you need more, especially if you feel that your mental health is declining, you feel overwhelmed consistently, or if you feel that people around you don't really understand what you're facing. Make sure you know who you can turn to during these times. You can always go to a GP, go visit a school counsellor, mental health charities like Young Minds or Couth, and child and adolescents mental health services. These professionals are specially trained to give you advice and guide you through your difficulties, so never be afraid to reach out to them. The strongest people are those who know when to ask for help, and everyone here deserves to feel supported, seen, and understood. My final takeaway would be to start building your support network now. It doesn't have to be limited to people that want to do medicine. What really matters is knowing who you can turn to and having people who can support you. That in itself is already a huge step forward. Thank you.
Thank you so much, Neha. So I hope you enjoyed that weekly webinar. I hope it was useful. Thank you for sticking out till the end. And I'll just send you the link for the attendance form. Please make sure to fill it if you want the certificate. And yeah, I'll stop sharing my screen now. And if you have any questions, obviously put them in the chat.